Assalamu alaikum wa rahmatullah wa barakatuh. Hello everyone, this is Dr. Osama Audat. I'm an orthopedic resident. In this series, I'm going to be talking about the hot topics for medical students that are going through the orthopedic rotation. So we will be talking about 15-20 lectures for the most important hot topics that are coming in the exams. We will start by the basics, then we go to the fractures, then we finish by the subspecialties. For today, we're going to be talking about bone histology, metabolism, and joint anatomy. And let's start. So the outline will be talking about functions of the bone, classifications of the bone, what are the parts of the long bones, and what is the bone composed of. Then we will go to remodeling and turnover, age-related changes of bone, and finally anatomy of some joints. As you all know, the functions of the bone are like a lot. So one of them is to support your body, support the muscles, to protect, like the skull, like the rib cage is protecting the vital organs, movements by the joints, mineral storage like calcium, phosphate, and so on. And one of the most important functions is hematopoiesis. So it's producing the blood content like white BCs, platelets, red blood cells, and so on. So if we're talking about the bone classification by the shape, we have 4 types of bones. We have the long bones, short bones, flat bones, and irregular bones. Let's take an example. So for the long bones, it's the bones that the length is much more than the width. So if we're going to take an example, we will take the femur for sure, or the humerus. So all bones of the limbs, most of them are long bones, okay? Humerus, the forearm, radius al ulna, the femur, the tibia, fibula, all of these bones are long bones. And we will gonna talk about it later, about the classification of these long bones. For the short bones, the most simple or the common example are the carpal bones, For the flat bones, we have the sternum, we have the skull, we have the ribs, and the scapula. So these are flat bones. And we will talk about a very important function for these flat bones later. For the irregular bone, like the spine, okay? So the vertebrae, the hip bone, the sphenoid and the ethmoid. So we have a lot of irregular bones in our bodies. Okay, very important, the anatomy of the long bones. As you all know, the long bones are like divided into epiphyses, diaphyses, and metaphyses. So what are the epiphyses? The epiphyses are the ends of the bone. So as you can see here in the cursor, this is one of the end of the bones. It's called the epiphysis because it's having the articular surface. And in the children, as you all know, they are growing. So they have a line. This line is called the epiphyseal line or epiphyseal plate, which is the bone growing or the bone formation starts here for the long bones to become longer. So the child is going to grow. So for the epiphysis, the articular surface, so this is the proximal epiphysis and this is the distal epiphysis. So we have 2 epiphyses, one proximal and one distal. Now, if we go to the second part, it's called the metaphysis. This area between the epiphysis and the diaphysis is called the metaphysis. And we will talk about the different types of bone that are filling the epiphysis, metaphysis, and diaphysis. So we have the epiphysis here, we have the metaphysis, and one of the most important, like, let's say, one of the most important specifications for the metaphysis is it's very rich in blood supply. It has cancellous bone, okay, that we will talk about in a few minutes. The third part, epiphysis, metaphysis, and the third part is diaphysis. The diaphysis, which is the longest part, it starts from the metaphysis to the other metaphysis. So from the proximal to the distal metaphysis. Usually we divide it into 3 parts, which is the proximal 1/3, like from this part, the middle third, and the distal 1/3. So when we want to describe a fracture, we should say, for example, this fracture is involving the humerus in the proximal 1/3. diaphysis. Okay, so this is important to locate the fractures you will be talking about. Okay, for example, or very important to know, in the diaphysis, as you can see in long bones, there is like it's from inside, there is nothing inside, it's evacuated. So it's called the medullary cavity, the medullary cavity. So the medullary cavity, inside it has the endosteum, and it's called the marrow cavity too. So inside there's a lot of mesenchymal cells, which is regenerating the bone. Okay, as you all know, everything in our body has a covering. For example, the muscles, they have a fascia. The bone, it has an outer covering, which is called the periosteum. Peri, it's outside, osteum, bone. So it's outside the bone. It's called periosteum. It's a tough membrane. It's covering the bone, and it has two very important layers. The first one is the fibrous layer, which is a dense, irregular connective tissue. It's a dense connective tissue. And the osteogenic inner layer, which is doing the job of bone formation. So bone cells and blood vessels that nourish or help with the repair. This is very important because like before 30, 40 years, when they were going into a surgery and they were exposing the bone, removing this nice periosteum, and they were fixing fractures, but unfortunately, there was no bone healing. Why? Because they were destroying the osteogenic layer of the periosteum. Okay. This is a histological like picture you can see. We have here the main system of the bone. You can see in here. This is the circular part. It's called the osteon, or it's called the Haversian system. If we go to the outer side, let's see here the periosteum. You can see the outer fibrous layer and the inner layer, which is the inner osteogenic layer we just talked about, okay? If you go more inside and more deep to the bone, to the medullary cavity, just go inside here, you can see there is a lot of blood vessels, which called the endosteum, and there is the mesenchymal cells. Okay, so the bone structure, usually what's happening, there's something called the osteoid. What's the osteoid? When the osteoblasts, which are the bone formation cells, are making the new bone, which is not mineralized yet. So the bone is being made. There is no calcium, phosphorus, hydroxyapatite inside it. It's called the osteoid, okay? After mineralizing of this bone, it will be called woven bone, woven bone. But the problem with this bone that the collagen is disorganized yet. After the collagen is being organized, which is the process of fracture healing, it will be called lamellar bone. So the lamellar bone, it is the mature bone, which collagen fibers are parallel and form multiple layers. So we have two types of the lamellar bone, two important types of the lamellar bone. Number one is the compact bone, the compact or the cortical bone, and the cancellous or trabecular bone. Okay. So if you can see here, you can see the woven bone, which is the blue arrow is aiming at. This is called the woven bone, which is the bone that's having calcified, but it's not organized yet. Then it will become lamellar bone. As you can see here, it has collagen aligned and well formed. Okay, so we've said like compact and or cortical and the cancellous. What's the difference between the cortical and the cancellous? For the compact bone or the cortical, it's a dense and strong bone tissue. It's like the Haversian system that you are seeing here. This is called the compact bone. You can find it in the outer wall of the long bones, okay? And the system is called Haversian or osteon system. In the body, we can see this compact bone in places where we need support. So the femur, for example, is having a lot of compression, so it needs to have very good support. So we have the compact and cortical bone in the outer space. Between the Haversian system, there are connections that will give the blood supply to called the Volkmann's canal. Volkmann canal. Okay, so this was the compact bone. Now we're going to the cancellous bone. For the cancellous bone, it's called the spongy bone. Spongy bone. It looks like a honeycomb appearance, as you can see in the picture. It makes 2/3 of the bone surface. Where can we find this? Where we need compression. So where there is more compression, there should be sponge bone, because the bone is elastic and it can accommodate compression. So when we need compression, there should be cancellous or spongy bone. Okay, so these are the two types of the bone, the cancellous and the cortical. You can see here, the green line is the cortical bone and the inside is the cancellous. So this is the periosteum histologically, you can see it. It's this line, it's called the periosteum, the covering. And inside, you can see the endosteum, which is very thin in comparison to the periosteum, because the periosteum is the bone formation, osteogenic layer, that's why it has to be thick. The bone structure, the bone structural unit, which is on the, if we gonna call it in other names, okay, it's called the osteons. So you can see it in here. These are the bone structural unit, the osteons. Very, very, very important. Where does the bone get its blood supply? Where can we get the blood supply? It's very important. We have two main things or three main things. Periosteal arteries. That's why we've just said that periosteum is very important for fracture healing, because before 50 years, they used to do periosteal stripping, so the fractures were not getting healed. That's why periosteum is very important. So periosteum is number one, and it takes about 1/3. The second part, which is the nutrient arteries. So if you look at the bone, you will see some holes in it. These holes, the arteries are going inside. It's called nutrient arteries, going through nutrient foramens. So these foramens are, or the holes are called nutrient foramens. In the metaphyseal and epiphyseal arteries, they are supplying the red marrow and bone tissue of the epiphysis, okay? So we have nutrient arteries, metaphyseal and epiphyseal arteries, and finally, periosteal arteries. This is a very common question in the oral exam. What is the bone composed of? So if someone asks you what is the bone composed of, don't say osteoblasts or don't say minerals. No, you have to go wider. We have matrix, cells, and bone marrow. So for the matrix, we have organic and inorganic. For the organic, the most important thing that we're going to talk about in a minute is a collagen type 1. Inorganic, hydroxyapatite, calcium, phosphorus, and so on. For the cells, we have the three types of cells, the osteoblasts, osteoclasts, and osteocytes, and we have the bone marrow. So for the matrix, we've said that we have 40% organic. So what are the organic? Type 1 collagen, proteoglycans, which give the compressive strength, osteocalcin measures the osteoblastic activity, and growth factors. These are the organic. For the inorganic, we have the hydroxyapatite, calcium, phosphorus. Okay, let's talk about the cells. So in the cells, we have three main types of the cells. The osteoblasts. Osteoblasts are the bone-forming cells found in all bone surfaces, bone-building cells. So the osteoblasts are the bone formation cells. Okay. The second type is the osteoclasts. So the osteoclasts, they are giant multinucleated cells, as you can see in these pictures. The purpose or the function of these cells is to absorb the bone. Absorb the bone. So bone formation, osteoblasts. Bone resorption, osteoclasts. Finally, we have the osteocytes. The osteocytes are the mature, non-dividing osteoblasts. So the osteoblasts, after they being worked, they will get retired and they will go sit in the matrix and they will be named osteocytes. Okay, for the bone marrow, which is, the myeloid tissue, it's the production of the blood. We have two types. We have the red and the yellow. The red is the active form that's producing blood. It's more in childhood and young people. And whenever you are getting older, it will be exchanged with the yellow marrow, which is fat tissue. It deposition inside the red marrow, and it will be yellow, non-functioning, non-productive for blood cells. Now, the main bones that will stay producing blood, even if you're getting older, ribs, vertebra, humerus, pelvis, and the femur. So these are the most important sites. On the other hand, you have to know that radiation exposure will shift the red marrow into yellow marrow, okay? It will shift the red marrow into yellow marrow. So that's why it will be causing anemia and so on. This is a picture showing the bone tear-over. You can see here the bone lining, which is normal. The osteoclasts came and started doing resorption. It's activating. So it's starting the activation. Then when it's done, the osteoblasts will come, cover that area, and will start formation of a new bone until it's getting back to its normal shape. So this is called bone tear-over or bone remodeling. It's very important to have bone remodeling because old bone, okay, should be replaced with a new bone. And to meet the individual bone function, because, you know, when you're getting older, you're getting fatter, the biomechanics of your body, the femur, the shape of your lower upper limb has to adapt with your new biomechanics. That's why your body is in continuous reshaping of your bones. And for calcium hemostasis, for sure. If we will talk about the sequence of how does this happen, it has 4 main stages, okay? Activation, so the osteoclasts are coming, it's being activated, start resorption, the second stage, then the reversal, the osteoclastic activity will decline, and then the pre-osteoblasts, which is the bone forming cell precursors are coming in, then formation of a new bone. So this should be taking about 4 to 6 months. A nice information, when a new bone is being produced, there in histology, you can find a line which is between the old and the new bone. It's called the cement line. You can see it here in the histological picture. You see this line, it's called the cement line. This is another cement line. So this was the old, newer, and newer bone. So whenever it's producing a new bone, it's called the cement line between them. So as you can see in this picture, these are the cells, the multinucleated large cells that have a rough border in this side. This rough border is giving HCl and cathepsin, which are enzymes that will eat the bone. Okay. This is the Ruffle membrane, as you can see. And you can see here something called Hauschip's lacunae. The Hauschip's lacunae is called the footprint of the osteoblasts where they are eating the bone. So you can see in this picture the unmineralized osteoid, the new bone formation. This is the new bone formation, which does not have still mineralizations. These are the young osteoblasts that came after the osteoclastic activity stopped, and they are doing bone formation. And if you look here, you can see these osteoclasts are entrapped inside. So the the osteocytes are entrapped in the matrix, which are the osteoblasts that stopped working. They are inside here. And if you go look here, look here, you can see that there are some remaining communication between the surface of the bone and the osteocyte. So it gets its nourishment. It's very obvious in these arrows. Okay, now we know the remodeling of the bone. Let's talk in brief about the factors that are affecting the bone turnover. So we have the somatostatin C, increased osteoblastic proliferation for sure, tumor necrosis or tumor growth factor, which is increasing osteoblastic activity, the interleukins or osteoclastic activating factor increases osteoclastic activity, and it's very obvious with the myeloma. Prostaglandins increases bone turnover, and you all know that it's part of the inflammatory process, the prostaglandins. Bone morphogenic protein, it increases the bone formation. So these are the local factors that might influence the bone remodeling. Now for the hormonal, we have the PTH, we have the calcitonin, we have the estrogen. You know, the PTH, when the PTH goes up, it increases the calcium inside the bloodstream. So it will cause resorption from the bone. The calcitonin, okay, it's the other way around. And estrogen and testosterone are very, very, very important in stimulation of bone growth. That's why people who have deficient estrogen or testosterone, they will end by early osteoporosis. So estrogen, it increases the absorption of calcium in the gut and decrease reabsorption by the bone. Glucocorticoids decrease absorption from the gut, increase reabsorption. That's why the people who are on chronic use of cortisone, of glucocorticoids, they will end up by osteoporosis. Thyroxine, actually, it enhances both formation and resorption. But if you take the net, it will be bone resorption. That's why people who are having thyrotoxicosis will end up by bone resorption. If we go for other factors, rise in temperature increases bone formation, acidosis increase resorption, alkalosis decrease resorption, because more acidosis, more HCl. HCl will cause, you know, as cathepsin and HCl are going or secreted by the osteoclast, increasing the resorption. Dietary phosphate inhibit resorption, and it's adopted as treatment for osteoporosis. Okay, mechanical stress. There is a law, it's called Wolff's Law. Wolff's Law says where there is compression, there will be bone formation. If you can see here, this line, this white line in here, this is the line that your weight is going through the femur. It's called the mechanical axis. The mechanical axis is where your weight going through the bone. So this area has the most compression site in the bone of the femur. That's why in X-ray here, you can see that it's much, much more white because a lot of bone formation. So gravity influences, muscle activity, load bearing, and vascular supply. These are the main influences for Wolff's Law, for bone formation. So Wolff's Law, where there is bone compression, there is bone formation. Mineral exchange and bone turnover, I'm gonna go through it like fast. You know that calcium is being stored mostly in the bone. Only, I think, 1%, less than 1% in the extracellular. So as you can see in this picture, most of it is in the bone. Parathyroid hormone is the most important hormone that's regulating movement from calcium from the bone into the blood, and for sure along with the help of the kidneys. So if the calcium is going down, there will be going up for the parathyroid hormone. So the parathyroid hormone will release calcium from the bones, okay, and it will increase reabsorption of calcium from the renal tubules, and it will activate vitamin D, which will increase reabsorption. So parathyroid hormone actually is working on 3 places. First of all, intestine to reabsorb by vitamin D. Number 2, renal reabsorption. Number 3, release calcium from the bone. Now for vitamin D, we will take this picture as a conclusion. You all know that vitamin D is already in the body, but it is inactive, the vitamin D3. It is in the skin. When you have the sun going to it, it will be changed, okay, to the vitamin D3, and it will go to the liver. In the liver, it will get hydroxylated to become 25-hydroxycholecalciferol, okay? Then this product will go to the kidney. In the kidney, it will get another time hydroxylated. It will be 1,25-dihydroxycholecalciferol, which is the active form of the vitamin D. And you can see in the picture, we have something called the feedback inhibition. The more 25-hydroxycholecalciferol we have, this will inhibit the hydroxylation in the liver, okay? Okay, so after that, after we have the activated form, it will go to the intestinal epithelium. It will increase the calcium binding protein, calcium stimulating ATPase, alkaline phosphatase, which will by the net increase the intestinal absorption of calcium. And finally, it will go plasma calcium ion concentration will go up. And when it's going up more and more and more, another feedback inhibition will go to the parathyroid hormone. So this is a feedback inhibition. So when the calcium level is going up, the PTH will get suppressed. And the other way around is true. Whenever the calcium is going down, the PTH is going up. So we can raise the calcium again by, for example, the vitamin D. This is another picture showing the hydroxylation or the path of the vitamin D. Another picture. Okay, for the phosphorus, it's available for sure in the diet. It's being absorbed in the small intestines. Absorption is reduced in the presence of antacids. That's why people who are taking antacids, famotidine, Magnesium, omeprazole, so whatever, they are taking antacids, especially the drugs they are taking for heartburn and so on. These drugs will bind with the phosphorus in the gut and it will decrease the absorption. An increase in the one will cause the other one to fall. So whenever the phosphorus is going up, the calcium is going down. Whenever the calcium is going up, the phosphorus is going down. So that's easy to memorize. So the regulation of the plasma phosphate are two things, the vitamin D and the PTH. Okay, the vitamin D and the PTH. The more PTH is going up, okay, it will absorb calcium and it will release phosphate. So the PTH does not like the phosphorus. Well, magnesium is important. Magnesium is important. It's play like a small but important part in mineral hemostasis. Magnesium is necessary for the efficient secretion and peripheral action of parathyroid hormone. So the parathyroid hormone needs magnesium to function. PTH is going, as you all know, from the chief cells, from the thyroid gland, and it's active being, it works on the renal tubules, intestines, and the bone. This is a graph showing after giving the patients the parathyroid hormone. Look at the calcium level, it's going up, and the phosphate is going down, as we already mentioned. So this is like a graph that summarizes everything. Like we have plasma calcium, parathyroid hormone, it's increasing, it goes to the bones, and calcium in the bone, it mobilizes the calcium to the plasma. In the kidneys, increased renal calcium resorption, activation of vitamin D, so more resorption from the intestines. In the end product, it will be increasing in plasma calcium, which is having a feedback mechanism another time to the parathyroid hormone. Calcitonin basically is the vice versa, or the other way around for the parathyroid hormone. So it's being produced by the C cells of the thyroid, more or less the opposite of the PTH. Plasma calcium, okay, if the plasma calcium is going down, parathyroid gland works, PTH, plasma calcium returning to normal, and the other way around is true. If the plasma calcium is going up, thyroid C cells are increasing the calcitonin. Calcitonin will rise and plasma calcium will going down. Estrogen is very important for sure, as we said. That's why postmenopausal woman is complaining of osteoporosis. Thyroxine is the net for resorption. Okay, age-related changes of the bone. In the youth, bone increases in size and changes in shape, for sure. Adolescents to 35 years, you have increasing in bone mass by 3% each year. 35 until 50, you start to decrease by 0.3% per year. And after that, imagine you're getting like postmenopausal women, 3% per year. That's why they are going like peak, then they drop because there is no more glucocorticoids, and after 65, bone loss rates slow down. This is a picture showing a normal and osteoporotic bone, as you can see in the picture. So this was like the main factors influencing the bone formation, vitamins, and so on. We will end in the last minutes by talking about the joints. And as you all know, there are a lot of like joint types, we're gonna be focusing on some. We have the hinge joint, which is like the elbow, which is moving only in one axis, okay? Only one axis, flexion extension, and that's it. We have the pivot joint, which is the rotation, okay? We have the ball and socket, which is giving you a wide range of motion, like the shoulder, the hip. The problem is more range of motion, less stability. Less range of motion, more stability. This is important to keep in mind. The shoulder, for example, it's a ball and socket. You can see here the proximal humerus is articulating with the glenoid. Okay, it's very shallow, wide range of motion, less stability, more dislocations. Elbow joint, hinge joint. We have the bony part, which is the ulnohumeral ligament, okay, and the radiohumeral ligament, and the proximal radioulnar joint. So this is the elbow joint. It's moving only on one axis, which is called the hinged joint. The hip joint, like the shoulder, ball and socket, it's more deep because we have the labrum, it's making it more deep. For sure, we have a labrum in the shoulder too. The knee joint, femur with the tibia, and we have the patella. So we have the patellofemoral ligament, patellofemoral joint. We have the femur with the tibia, the knee joint, okay? And we have the fibula is with the tibia on the lateral side. I'm not going to go into details with the ligaments because we're going to talk about it in each lecture for each joint. And I think this is all you have to know for the basics. I don't want to say all, most of the things you have to know in the basic. Thank you. And I hope we're going to meet in the next lecture. It will be mostly about fracture management. Thank you very much.